Hey everybody, welcome back to the Dr. Terri Show. Today I am in the studio with Dr. Johnny Peet, one of my favorite people to co-teach with. We teach together clinicians across the country, and he's just a wealth of knowledge. He's a board-certified gynecologist in the Woodlands, Texas. He's the owner of both Woodlands Gynecology and Aesthetics and the Woodlands Medical Aesthetics Institute. Dr. Peet is an innovator in the fields of gynecology and sexual medicine, and really integrative medicine and an integrative approach to medicine. Today we're going to talk about thyroid, and the first question is, why is a gynecologist talking about thyroid? You're going to figure that out. He's brilliant with thyroid. But if you have suffered from symptoms of low thyroid, like cold hands, cold feet, depression, anxiety, mood swings, fatigue, can't lose weight, constipation, sluggish metabolism, and you've been told your thyroid is normal, this episode is for you. Join us in the conversation. Hi, Dr. Peet.
Hello. Good afternoon.
Thanks for coming in so early. I know it was a big drive and long part of the day that you didn't have to come in this early, but I appreciate it because you have a lot of stuff in that brain of yours that I want to share with people. One of the number one things that people ask me questions about, I know you know this, especially when they come into our offices, is thyroid. And, so many women, especially, it's primarily women, some men, not as much, but will say, I have this symptom, that symptom, that symptom. I'm cold all the time. My metabolism is sluggish, all the symptoms of low thyroid, which you're going to talk about. But I went to my regular practitioner and they said my thyroid's normal. Hear it every day, probably. And so when I'm trying to explain, thyroid to people, and when we kind of spell it out the way you and I talk about it, it's kind of an aha moment. So the first thing I just want to say is I want you to give your backstory, because a lot of people may wonder why a gynecologist is managing thyroid, and especially in men and women, right? So just tell us a little bit about your progression from traditional gynecology into where you are now and how you practice now, and then let's get into a little bit of a thyroid conversation.
Happy to. Thyroid's probably my favorite topic to discuss. Yeah. So goodness, let's see, it's probably 25 years ago when I first got out of my OB-GYN residency and moved back home. I was shaving one morning and I said, what is that lump in my neck? I should have seen that before. Uh-huh. And sure enough, I had thyroid cancer at age 30. And so after thyroidectomy, radiation therapy, and then getting scans every year or two for a few years, they said, okay, you're stage 1, everything's fine.
Cancer-free.
Cancer-free, but you don't have a thyroid. So now we're left with a new problem, and that is replacing your total body metabolism. Right? With a pill or with something. Right. And so like so many other people in the United States, I was placed on a synthetic T4, or Synthroid, which is the largest single grossing medication in the history of the world as far as money's concerned for big pharma. Synthroid, and of course it's been replaced with the generic levothyroxine. So these are synthetic T4 products. So I languished on that medicine for over a decade. Wow. Probably. Yeah. Never really feeling like I used to feel, and I just kind of chalked it up to having a stressful, hard-working lifestyle of nights and weekends and holidays at work, and just kind of thought this is the new norm.
Well, but before you go on, what does that look like, just for people listening? Because I think a lot of symptoms of low thyroid are so vague, and we live with them, that people and clinicians don't connect the dots that it's thyroid.
Mm-hmm. So thyroid affects every cell in your body needs thyroid. We have receptors for T3 and T4 in almost every cell in our body. So there's no body system that's not affected by suboptimal or diminished thyroid hormones. It's everything. Right. The symptoms can be literally everything. Of course, the top few being fatigue, weight gain, cold hands and feet, thinning hair, constipation. Those are kind of the most common ones, but there's so many others, whether it's brain fog and joint pain and depression and anxiety and insomnia and acne and PMS and infertility. The list goes The list goes on and on. It's legion, and that's why thyroid is my favorite hormone to talk about, because it has the most impact on your life on a day-to-day basis. Without your thyroid being where it needs to be, you're not going to feel and function like you should on a day-to-day, every day in, day out basis.
Yep.
And unfortunately, in our big pharma world of medicine, we have been treating thyroid dysfunction incorrectly, or thyroid replacement, for, since the...
Well, and you figured that out with yourself, right?
Since the 70s, when Synthroid came out. Before that, we had Desiccated porcine thyroid, which is a compound or a pill that's bioidentical. It has T1, T2, T3, T4, and calcitonin, all the things that your thyroid gland makes on a normal basis that your body needs. And what people like to do in a lab, and we're trying to make money and get a patent, is we're going to just say, well, let's just take out this T4. It's the easiest one for us to use, and we'll give it to you, and you'll turn it into T3, and then you'll be happy, and everything will work well. And that's all just unicorns and rainbows. But in reality, it doesn't work like that. Yep. So our T4 levels and TSH levels can be pretty good, while your T3, which is the hormone that is it's the workhorse. T3 molecule is 5 times more bioactive than T4. So the reason we have this reservoir of T4 in our bloodstream all the time is so your body can take it. Your enzymes can take one iodine molecule off of that thyroglobulin protein, and now you have T3, and then boom, you have metabolism. It hits the receptor, you've got energy, you've got metabolism, all those things that you need. And unfortunately, when we just dump in a large load of T4 only by itself, your body doesn't know how to handle that. That's not how it came out of your thyroid gland initially. So when you have a ton of T4 all at once in a big load,
like a pill, like
Synthroid or levothyroxine, your body says, whoa, wait a minute, we don't want to have too much T3 here. We're going to downregulate those enzymes so you don't make as much. And all of a sudden, we're going to upregulate some of these enzymes that make the opposite of T3, like reverse T3, to block it. So your T4 levels may be great, and your pituitary may say, hey, I like our T4 levels, and I like our pituitary T3 levels, and your TSH will be normal. So your pituitary hormones are fine, your T4 is fine, but boy, we know now why people don't check a reverse T3 or an actual free T3, the lab test that's needed to know your metabolism.
And the only one I wish anybody would ever test, ever and again. Amen.
Yeah, we can treat thyroid all day long without any lab tests. But a free T3 is kind of nice to have. But if we were looking at reverse T3 and free T3 levels in all these patients who are on synthetic T4, the reason why they're not feeling good is right there in front of you. But none of us were ever taught how to order the right lab test. And none of us were ever taught through medical school of how to really interpret what that lab test means, which is super important. Because what did you say in your intro? I see it not just once a day in clinic. If I'm in clinic all day long, I see this 3 to 5, 6 times a day. I've had my thyroid lab test done, and I'm told that they're normal, but I have every symptom of low thyroid.
Every day. So, let's talk about those. Well, first, before we talk about the different lab tests, how did you make the transition from traditionally trained, and you've been on levothyroxine, and now you're such a proponent of the complete opposite of what's being taught? And I am too, obviously, because we see what works, but share that transition for us.
So after about, 13 years in private practice, OB-GYN, covering 3 hospitals and ERs and taking all comers and just in private practice, it never stops. During that time, I didn't have time to really even evaluate or investigate why I wasn't feeling good. I just had to get through tomorrow for 13 years. And so in 2013, 12 years ago, I stopped delivering babies and then realized that I had time. And so I said, you know what, I'm going to figure this thyroid out. And on top of that, I wanted to look into hormones a little deeper because I didn't feel like I was taught much about hormones as an OB-GYN.
And you're an OB-GYN. Aren't you the specialist in hormones?
Oh, I can. We're taught the top 10 big pharma drugs you can give with all kinds of bad studies about them. But I didn't really know and understand hormones. I really didn't. And certainly didn't understand testosterone, which we've talked about before, because no one prescribed it.
Right. It's such an
especially not for women. So I didn't know anything about testosterone. I was using synthetic oral estrogens. I was using synthetic progestins orally, and I was using synthetic T4. Right. Everything that we were taught.
All the bad stuff.
None of those things that work well, and all of them are dangerous.
And were your patients coming back every year with the same problems all the time?
Pretty much. So I just ignored it, did their annual exam, and said, I'll see you next year, because there's no reason for us to talk about these 30 symptoms you're having, because I don't know how to fix them.
Right.
No one ever taught me how to fix them, and I don't have time anyway.
Depression, moodiness, anxiety, can't sleep, can't focus, low libido, joint pain, chronic pain, yada, yada. I mean,
if every patient comes into your office with all those symptoms, how long is your day going to be?
Yeah.
If you try to address them with every patient, it's impossible.
Well, we could just go ahead and just write that script for Prozac. I think that's
you know what? And that's the quick, easy thing to do. Maybe
Band-Aid.
If I give you a psychotropic medication like that, you won't care enough to complain about it anymore.
Exactly.
And I won't get any phone calls.
And we're saying it tongue in cheek, but it's sadly the reality, you know, of band-aiding, you know, reactive medicine and band-aiding symptoms rather than looking at the root cause. So I love that.
Allopathic medicine has become so prescription-centric,
right?
That what we look at is, here's a bunch of symptoms of, let's say, thyroid deficiency. Here's a bunch of symptoms of, let's say, androgen deficiency. But since we don't know how to fix those two things, I'm just going to give you something to treat your symptoms.
Yeah,
right?
Xanax, Prozac,
exactly.
Ambien.
The whole bit.
Yeah.
And that's what the whole world is on, all of these medications, and they're not feeling any better.
Right.
And when we talk about metabolism in this country, I saw a study yesterday that absolutely was a jaw dropper. In 1990, there was not a single state in the U.S. that had over 20% obesity rate.
1990, that wasn't that long ago.
Right. Do you know what it is in 2021?
I can't even imagine.
100% of the states have 20% obesity or more.
Wow.
Every one, all 50.
Yep.
In just 20-something years. So, and I can go on and on about the food that we eat and the snacks you were talking about earlier.
Disruptors,
that is a huge part. But I can tell you, thyroid plays a massive role in this, a massive role. It's my firm belief that probably 2/3 of women over 30 need thyroid. And probably 1/3 of men over 30 need thyroid. Their thyroid is so low that it's not just a metabolism problem, it's a health condition.
Absolutely, because you know we've talked about this, that you've said it already, in every single body system, you know, thyroid is needed, and we're seeing it so much younger and younger people having heart attacks and these chronic diseases. That no one ever, does cardiology check free T3s? I mean, you know, maybe progressive ones might, you know, but they're not thinking about how the impact of thyroid on the heart. I mean, I was looking at a study the other day, just how many 30-something-year-olds, and directly correlates with the obesity problem, but which came first, the chicken or the egg, are having, you know, chronic diseases that we never had before. And I do believe as well that thyroid could be a root cause of a lot of that, and all the hormones really being disrupted can be a root cause of that. I think there's a lot of confusion with people. We're all smart consumers. We have, you know, Google that we can look up stuff, but there's still so much confusion about all the different thyroid labs. And when a person goes to their clinician, doctor, nurse practitioner, PA, whoever it is, and gets their thyroid labs tested, and they're told your thyroid labs are normal, can you just kind of distinguish out the different thyroid labs and what it means and what we really are looking for, what we're looking at and what we should be looking for? Because I think that would be really helpful. And if you want to draw it out,
I'll draw a little bit out if I can.
People.
Maybe you can still hear me if I move this mic. But your pituitary in your brain sends out thyroid stimulating hormone to stimulate your thyroid gland that's in your anterior neck right here to make more thyroid hormone. Your thyroid gland will make, like I said earlier, T1, T2, T3, T4, but the most abundant is T4. Okay, now T4 has some activity, but really has to be converted into T3 in order to have its action. So there are enzymes there called deiodinase enzymes that take away that iodine, and that creates the T3. Now this molecule, like I said, is 5 times more bioactive than this one, and that's the end point of what you really need. But what are people getting when they're getting prescriptions? They're not getting T3, they're getting T4, Synthroid, levothyroxine, right?
Unless they're getting a desiccated combination like Armor NP thyroid.
Armor or NP thyroid is going to have everything in it that a ground up thyroid would have. So most of the time people are getting a TSH checked. That is a screening test, right? A screening test means we're going to take just an asymptomatic general population and we're going to check it, just screening for possibilities that there might be a thyroid issue. And it's a moderately good screening test, okay? This test was never designed to monitor therapy. Right. But it is unfortunately used that way or misused that way. And since most people are getting replacement with synthetic T4, then these are the only two labs that are really ever being checked.
Yep.
Right? Is your T4 normal? Did your TSH come down when we gave you a little bit of Synthroid? Well, then yes, everything must be fine. But this is the problem here because they're not looking at this.
Right.
And most folks that are on synthetic T4 actually have a very low T3, very poor conversion to T3, and they also have an elevation in reverse T3, which is a mirror image molecule that blocks the receptor. So you can have low T3 and block your T3 just by taking this naughty medicine.
But your thyroid is normal.
Normal. So they're going to go in and because they're going to check a T4 and a TSH and everything must be fine.
What are your thoughts on, before we go into all the things that can cause that deiodinase enzyme to not exist, because there's a lot of things. Mm-hmm. What are your thoughts on the lab reference ranges of TSH? Because I do believe even there's some people that get their TSH checked, it's in the normal range, but because nobody's checking that T3 for that low free T3 syndrome, they're told their thyroid's normal as well. Mm-hmm. So it may not be a person that's on T4 medication that's suppressing their TSH, but just a general person that comes in and their TSH is, let's say, 3, which I think is high. Because with TSH, the higher the number, the lower your T4 production is, essentially, if you want to think of it like that. When TSH is low, T4 production is good, just for everybody listening. And so, but I think I think our reference ranges are a problem, and I love it when you explain reference ranges because it really clicks. So talk about reference ranges.
So reference ranges and really and truly,
lab reference ranges.
There should be two different ones because TSH is a negative feedback loop.
Right.
Okay. So if your brain thought, I have enough thyroid hormone, thyroid, you go to sleep, I'm going to stop stimulating you, and your TSH went to 0, what does that mean? Does that mean you have too much thyroid? Or does that just mean you have enough and your negative feedback loop turned off?
Right.
There shouldn't be a reference range for a negative feedback loop.
You're right.
Because if the result is 0, that means that your brain's happy with the amount of thyroid you have and it's not stimulating your thyroid anymore.
But so many clinicians think your thyroid's too high because your TSH is low. Like, no, my brain's just happy.
Yes, and in addition to that, now if someone walks in and their TSH is 0, well, there's probably an issue going on. But if someone is on replacement therapy, right? Then a low TSH really means nothing most of the time. And the reason is because these deiodinase enzymes, about 20% of your T3 is made right in your thyroid gland and put into your bloodstream. The other 80% is converted in the periphery at your tissues. These enzymes are taking that iodine off and activating your thyroglobulin, your protein there. So what's really, really complicated and why the TSH should not be a screening test is because the pituitary has its own enzymes to convert T4 to T3.
Yep.
Okay? So your pituitary may not know what your T3 level is in your bloodstream at your heart or your kidneys or your lungs or anywhere else.
Just knows the brain.
Inside the pituitary, deiodinase enzyme 2, the only place it's found is brown fat and in the brain. So the pituitary can take T4 and convert it to T3, and you can have a great level of T3 in your pituitary, and your TSH will come down and be low, while the rest of your body is dying for T3 and suffering and doing poorly. So once someone's on therapy, the TSH is a useless test to monitor therapy.
Right.
But let's just talk about free T3, and this is important. So we're going to talk about reference ranges, and I write these reference ranges out to all of my patients on their lab slip, and I say, you know what, you said you'd never have to look at a bell curve again after you got out of high school math, but I'm sorry, here it is again. You're going to have to see a bell curve in order to understand what your labs show. So let's just pick a reference range. Let's say that every lab has their own reference range, right? So let's say this is 2, this is 3.2, and This is 4.4. That's the lab I'm currently using. What does this mean? When you see a T3 level, right under it is this little range, reference range. It says 2.0 to 4.4. What does that mean? Well, number one, it's not a normal range.
Right.
That's what is, unfortunately, we as physicians say, well, that's the normal range. If you're in between these two numbers, it must be normal. The reality of it is that's a distribution in the population of that lab test.
It's an expected range.
If you took 2,000 women and checked their free T3, you could plot the results on a bell curve. 95% of the results would fall between this number and this number. There's your reference range. 2.5% would fall above, 2.5% would fall below. The most common result that we would get would be right here at the median, where we'd call an average, okay? Now, that is a distribution. It's not a normal range.
Right.
And for us to say that if someone is at the 2.5th percentile for T3, that's normal, that's ludicrous.
And it's the expected range of the average of really a relatively unhealthy population.
That's a whole nother topic.
Yeah.
So we're creating a reference range from a group of adults who all need thyroid.
Yeah.
50% of, 100% of the states now have 20% obesity or greater. This is a country that has awful thyroid function for a million reasons. But we make a bell curve and a reference range out of all these people with low thyroid.
What is the average thyroid for an 18-year-old on the bell curve?
It's going to be over here on all of them. When you are a teenager and even an infant and a small child, you're going to run in the 6, 7, 8, 9, 10 range all the time, right? And that's why when you're a teenager, you can eat and drink all you want and not gain a pound. But then now that we're in our 40s and 50s, our metabolism slows down. There's no question. The longer that we live on this toxic planet with the air and the water and the food that we eat and drink, the worse our thyroid function gets.
Right.
But we can actually replace it. So these poor ladies that have been told that they're normal, they're usually sitting down here at the 10th percentile. So
100%.
I tell them, thyroid is a metabolic hormone. That means the more you have, the more effect you have. Okay? So that means that there may be something different between the 10th percentile and the 90th percentile. This person here at the 10th percentile, what does that mean? Well, that means that 90% of the world has more thyroid than them. They're tired, they're gaining weight, they're losing hair, their hands and feet are cold, they're constipated, you name it.
They're depressed, they're anxious, they're
everything. But they've been told every year that their thyroid's normal. And the endocrine societies will tell you not to treat until it's below the 2.5th percentile. So we just have to tell this poor lady to come back in every year and get retested. And maybe 5 or 10 years from now, she'll fall below this point if she's still alive, and then I can treat her. Okay? So what if you're at the 90th percentile for T3? This person may not have any of these symptoms, and they may feel pretty good. But we're going to turn around and tell these two people that their thyroid's the same and they're both normal just because they fall between these two numbers.
Great.
That is nonsensical.
Right.
But that is how we were taught as physicians. And over time, as I began to treat patients with bioidentical desiccated thyroid, and I began to follow free T3 levels instead of T4 levels, and I began to ignore the TSH after I've initiated therapy like everyone should do, then it became quite easy because I asked folks, where would you like to be as metabolism? What percentile, which quartile would you like to live in with your metabolism? It's not really, it's not a trick question. I mean, everyone gets it, right? So how about 3.8 over here at the 75th percentile? How about living in the upper quartile of the reference range instead of the lower quartile?
Well, and you present studies that show you have better clinical outcomes and less disease and death when you live on this side, right?
There are long-term studies that show if you are in the lowest tertile of the T3, lowest tertile, you have an increased risk for Alzheimer's, dementia, and all-cause mortality.
All cause of death.
All-cause mortality. You are more likely to die if you're below the 33rd percentile of free T3 than if you're up in the upper tertile.
But nobody's checking it.
Right. Not only is no one checking it, the endocrine societies will tell you that if they're here, they should stay there. That there's something wrong with moving a person from here to here.
Yeah.
What would be wrong with moving a person from the lower quartile of metabolism to the upper quartile of metabolism?
Yeah, and heart health and brain health. And
when we talk about heart health, all over the cardiology literature right now is low T3 syndrome.
Yes, finally.
All over. And it is probably a mechanism for heart failure.
Yes.
And why is that the case? There is only one tissue in the body that does not have the enzyme, deodorinase enzyme 1, to convert T4 to T3, and that is the myocardium.
Yep.
So what does that mean? That means that if your heart is going to get T3, it's got to get it out of your blood.
Yeah. It's the only way to get it.
It's the only way to get it. So if you're running around with a 10th percentile T3 all the time, even if you're on levothyroxine and your TSH is normal, you're going to have heart problems just because of that.
And you know, it blows me away about this when I learned this, you know, coming from an acute care background and working in the hospital and working with hospitalist group and even working in emergency medicine and having patients coming in with heart attacks and exacerbations of their heart failure. We never checked T3, ever. Now, the only time we might check a thyroid lab is if they had AFib and we checked a TSH. Woo!
Yeah.
I mean, you know, so it
has no correlation.
It has
with
no
AFib.
correlation. Yeah. So what are some things? And this is so eye-opening when I learned this. So the key thing is the deiodinase enzymes that convert T4 to T3, whether you're making thyroid or you're taking thyroid. Mm-hmm. List out some things. They're pretty rare that the average person might experience that will block the production of deiodinase enzymes.
As far as downregulation of those enzymes, these studies came out in the 80s. There are so many things that will decrease the activity of these enzymes and decrease your T3 levels and decrease your metabolism. Stress, dieting, autoimmune disorders, toxicities, mm-hmm. Almost everything that we all come in contact with. Yeah. Depression, diabetes, all of these things. And then once again, what makes that list is synthetic T4, levothyroxine and Synthroid.
So it's interesting. So a lot of the things that cause the downregulation of deiodinase enzymes are things that people are complaining about anyway. And then the downregulation of that and not having enough T3 exacerbates that condition, right?
And then you're stuck in it.
And you know, one of the big things I'm seeing right now with thyroid is so many of people are on these, you know, miracle drugs, the GLP-1s, like semaglutide and tirzepatide and these other medications. And I see them come into my clinic on these medications and no one's ever looked at their T3 and their T3 is low because they have done this amazing dieting, but dieting is one of the bigger things that can cause this. Mm-hmm. And so many people aren't looking at it. So that's great. And then what I see happening is I was on this medication for 6 months and it worked great. And now it's not working anymore and I'm gaining weight. Mm-hmm. Well, nobody ever looked at their T3. So their metabolism now is so sluggish that they start gaining weight because the body's in this fight or flight.
So we lucked out with our GLP-1s because we started doing thyroid optimization probably back in 2014. Yep. And we started doing testosterone optimization around the same time. Mm-hmm. So then when we had initiated GLP-1 therapy in 2022, which we have thousands and thousands of patients successfully doing, we didn't realize, well, the testosterone they're already on is saving them from losing muscle mass.
Right.
And the thyroid that they're on is making it work so much better. And then when they get off of the medicine, they're still on their thyroid and they're not gaining their weight back. Right? So if you're not on if your hormones aren't good, if your B and D vitamins aren't good, and your testosterone, your estrogen, and your thyroid are not good, you may lose some weight while you're on it, but it's not going to be long lasting. It's not going to be as much as you want. And then it's going to come right back when you're done because low caloric intake will down-regulate deiodinase enzyme 1 and you'll have less T3. So you'll get off of the medicine and boom, there goes your weight right back on.
And some people are gaining the weight back on the medicine and they think the medicine isn't working, mm-hmm. but what's really happening is their metabolism is sluggish because they haven't been addressed on their thyroid.
So the big main difference between synthetic T4 and desiccated thyroid is what happens right here with these deiodinase enzymes. If you just take all T4, you're going to down-regulate the amount of deiodinase enzyme 1 activity to T3, and you're going to upregulate the amount of reverse T3, which blocks it, right? This is your body buffering. Yeah. Your body is buffering the fact that you're putting this huge load of T4 in there, and your body's not used to that. That's not physiology. That's not how it's supposed to work. When you take desiccated thyroid, you're taking it all. T1, T2, T3, T4, and in addition to that, calcitonin. So you're actually getting the T3 right off the bat. Right. It's in your bloodstream. When you take an NP thyroid or an Armour thyroid, a couple hours later, your pulse is going to be 10 or 15 beats per minute faster. That metabolism is in the pill. You don't have to wait for it to convert.
Right.
But then in the background, you have T4.
Right.
And in the background, you're going to be converting more T4 to T3. There's no downregulation of this enzyme when you're on desiccated thyroid. So you're going to continue to convert like you're supposed to. In addition, there is no upregulation of this enzyme. So I see these labs over and over and over again when people come into me on Synthroid and they still have every single
symptom of
low thyroid. It's
even
like
though their TSH is
it's like they're not on anything, and they're never of normal weight. I check a reverse T3, a free T4, a free T3, and a TSH. And then after they converted over, 3 months later, I'm checking a T3, a free T3, and a reverse T3 again, and I just watch this number fall and this number rise. And while it's happening, the patient is waking up again. They're starting to finally feel better.
So good.
You've got to get this down, and the only way to get this down is to get rid of that synthetic T4. Even a small dose, 50 micrograms, is going to bump this up to the 90th percentile or beyond. And this T3, most people on the synthetic T4, wherever on the bell curve their T4 sits, their T3 is about a third of it. So if they're at the 60th percentile in T4, they're going to run about the 20th percentile in T3. It should be the same, right? But that's this down regulation that you see. So we have to get the reverse T3 as low as we can get it, and the T3 up here in this range, right? And wow, people suddenly have a whole new life.
And not only do they have a whole new life and feel better, it's been shown in studies that their chronic disease risk is much lower.
And we talked a little bit about cardiology. We have 1 million studies on that. But I like history now more than I used to when I was younger, and I've read a lot of books about the history of hypothyroidism and the history of treating it. And back in the old days when they only had desiccated thyroid and they had no lab tests, right?
A dream. My dream.
I would love it, But you could diagnose hypothyroidism in these people from across the room.
Oh, sure.
They had no eyebrows, big fat faces, very thin hair, mucin accumulation behind the arms. They were freezing. Their basal body temperature was so cold and their pulse was 50. I mean, it's very obvious. Do you know how 90% of those people died?
Heart attack.
Heart attack. Why? They had no T3.
That's right.
That's how they died. The best research that's ever been done on hypothyroidism was aimed at decreasing heart attack death.
That's amazing.
Back
it's
before
just now coming into the literature.
Back before we had synthetic T4 and the ultra-sensitive TSH. These two things right here have ruined thyroid care in this country.
And probably globally, I would say. Wow. Okay, so a couple of recaps for everyone listening. Normal is not optimal, whether it's your TSH or T4 or T3. And we want to make sure if you're getting thyroid labs from your clinician that they check a free T3. Even if they don't know what to do with it, you now know what to do with it based on this beautiful bell curve that Dr. Peet so brilliantly explained. And I really thank you for being here. And we're going to have some more fun conversations about testosterone and women. And isn't that a male hormone, right?
That's what I've heard.
That's what I've heard. So, so thanks for being here, and we'll talk again.
You're very welcome.
Thanks.